We're going to discuss some of the stenotic lesions now. You can refer back to that graph in your notes. And the first one we're going to discuss is pulmonic stenosis. The cusps are deformed, and so they open incompletely during systole, and they act as an obstructive lesion. So this is a right-sided outflow tract obstructive lesion. And so that means that there is less blood flow to the lungs. The right heart has to work harder, and so you will have right ventricular hypertrophy. It has to work that much harder to pump the blood through. If there is some kind of septal defect, then again blood takes the path of least resistance. If there's a VSD, when the heart pumps, some blood will make it through the narrowed pulmonary and out to the lungs, but some blood will just take the easier route and go across to the left ventricle, but that's deoxygenated blood, so you can't have some right to left shunting. Heart failure occurs only in the severe cases, and it depends how stenotic the outflow tract is. That determines symptoms and whether you go into heart failure or you get cyanotic or not. So here we have a diagram again showing there is the stenotic lesion. It's a little bit smaller than usual, and so it's harder for blood to make it out to the lungs, which means that the right heart has to work harder, which means it can cause right ventricular hypertrophy. Now you can see that if there's some kind of a defect, VSD, then some blood would go out this way and some blood would come across and cause some shunting. Again, on exam, you're going to find a low-pitched systolic ejection murmur. The location of the murmur is also important, so you need to review that, because the location will tell you if it's over the pulmonic area, if it's over the aortic area, and that lets you think about the pathology involved. You can hear an ejection click. Certainly, as the patient gets worse, and you'll have a decrease in S2, and the murmur gets harsher because the flow is faster. Chest X-ray with severe pulmonic stenosis reveals right ventricular hypertrophy and an enlarged heart. Also, because there's less blood flow to the heart to the lungs, if there's decreased blood flow to the lungs, on X-ray the lungs look blacker, and we'll show you that again with, for example, tetralogy of Fallot. You have these blacker looking lungs on X-ray. The EKG will show right ventricular hypertrophy. The best test, however, is the echocardiogram. And the treatment is going to be surgical or invasive cardiology. You can do a balloon septostomy where it actually breaks up that stenotic valve, or may actually need surgery to the valve. Aortic stenosis. Most aortic stenosis is caused by a bicuspid aortic valve. The aorta is usually a tricuspid valve. In this case, it's a bicuspid valve, and it's stiffer, and so it's a left ventricular outflow tract obstruction. Usually, a bicuspid aortic valve is picked up just as a murmur, and children are pretty much asymptomatic. It's a very common problem. You can have a valvular aortic stenosis, and a subvalvular aortic stenosis, and a supravalvular aortic stenosis. So depending upon where it's located, it's how it's classified. So the valvular could be obviously the valve itself. You can have stenosis above or below it. The subvalvular is basically a shelf. It's also almost like a septum, and that goes along with what we call idiopathic hypertrophic subvalvular stenosis, IHSS. The supravalvular stenosis is the least common of them all. Here we see that there's a left ventricular outflow tract obstruction. The aorta is smaller, or the opening is smaller, and sometimes what you have is a post-stenotic dilatation, because as the jet of blood comes out, it bangs up against that part of the aorta and causes a dilatation. Blood then has a difficult time exiting the left side of the heart and going out to the systemic circulation. The symptoms, again, depend on how severe the obstruction is. If you have a critical aortic stenosis early in infancy, these patients will go into heart failure very quickly. And the murmur may not be that loud because there's not much blood flowing through the defect, through that stenotic valve, so you won't hear the murmur. Mild to moderate stenosis can just be detected as just a murmur on physical exam. And rarely do you pick it up at an older child, and then they can have actually signs of of heart failure, or they can have syncope or angina. Sometimes the syncope occurs when they start to exercise, they just faint. Certainly once it's really severe, then you're going to see that the pulses are going to be decreased because of the severe obstruction. Showing you the outflow tract obstruction, you have a narrow aortic valve, and so you're going to have decreased delivery of oxygenated blood to the tissues. Things can back up, and the left atrium can actually become dilated too. The treatment is going to be a balloon valvuloplasty for moderate to severe, and if it's very severe or it doesn't work, then you're going to have surgery. And afterwards, once you do that, you're going to have some aortic insufficiency, and the patient actually may need later on valve replacement. Again, you're going to have a harsh systolic ejection murmur in a different location now. Look at the location. This is a second to third right intercostal space, which corresponds with the aortic area when you're listening to the heart. It will radiate to the neck and the left sternal border. You can have a narrow pulse pressure. Again, on chest x-ray, look for left ventricular hypertrophy, and certainly the best test again is going to be an echocardiogram. Coarctation of the aorta is a real important one, common one asked on the exam. Remember, we talked about Turner syndrome earlier. We said any girl with short stature, consider Turner syndrome. When we talked about Turner syndrome, we said worry about coarctation of the aorta. The aortic arch can be narrowed at any point, and actually the aorta can be narrowed at any point, but most typically we're going to see it at the aortic arch. And again, the age determines the presentation. We have what we call the infantile form, and we have what we call the adult form. The infantile form is usually preductal, and that's important to know for treatment, at least emergency treatment. Usually what you see is a narrowing before the ductus. Sometimes it includes part of the ductus or has some ductal tissue in it. What happens then is that blood just can't go past that obstruction. In this case, the ductus is very important because blood can go from the ductus out to the distal aorta and then to the rest of the body. Now, certainly that blood is deoxygenated blood because it hasn't gone to the lungs yet to be oxygenated, but it does have some oxygen in it so that the patient can then extract some of that oxygen. Not the best circumstances, but at least they're getting some oxygen. So you will see differential cyanosis. The lower extremities may be somewhat cyanotic, and the upper extremities won't be because the obstruction is not causing a problem to flow to the upper extremities. Older children, or the adult type onset or form of coarctation, it's a milder form, and it's actually juxtaductal or a little bit below the origin of the ductus arteriosus, around the ductus. Now, what happens with the adult form is it's not as severe, and so you will have better flow, and it's not picked up till later. Sometimes you will see that you will have decreased pulses in the lower extremities or delayed pulses in the lower extremities. The adult form is the one where you're going to see the classic rib notching on x-ray. It takes longer to manifest because there is a little bit better forward flow simply because it's not as serious an obstruction. It just takes longer to manifest itself. Now, with Turner syndrome, remember the higher incidence of coarctation. They also can have bicuspid aortic valves. Look for, particularly in the infant, when you're examining them, as the ductus closes, the femoral pulse gets weaker, and it eventually can actually go away. I remember taking care of a 9-day-old that was in the emergency department with blood pressure of 150/100 in the arm at 9 days of age. That's high for anybody, but especially at 9 days of age. And this baby was in heart failure and respiratory distress. On physical exam, you could not get pulses in the lower extremities, and the blood pressure was like 30/20. So that really helped with the diagnosis. Chest x-ray showed heart failure. This baby was intubated, obviously, and started on prostaglandins and eventually needed heart surgery. This had a coarctation of the aorta. So it's always important to check pulses and to check blood pressures in all the extremities. Over time, the milder form causes collateral circulation. Here you see coarctation of the aorta. If the ductus is present, you can at least have blood flow from the pulmonary down to the rest of the body, and it buys you some time. Once the ductus closes, you get into real trouble. Again, the chest x-ray depends on the duration of symptoms. You will not see the rib notching until later on in life, and we're going to show you an x-ray here that shows the arrows point to the rib notching, and that's because of the collateral circulation through the internal mammaries down to the femorals, but at the same time the collateral circulation causes increased blood flow through the intercostals, and they kind of erode away at the ribs and cause that. That's going to be in an older patient. In a neonate, you start prostaglandin to keep the ductus open, and you're going to need surgery. They will develop hypertension for a short period of time afterwards, and then it goes away.